Welcome to HCA Talks Health. I'm Zina Leroux, and my guest for today is Dr. and Professor Deepak Ravindran. So, Dr. Ravindran has over 20 years of experience in helping people overcome pain in the NHS, but also in his private practice. And he possesses triple certification in lifestyle medicine, musculoskeletal medicine, and pain medicine. So he's been a consultant in pain medicine since 2010 in big district medical hospitals, and he's also the author of The Pain-Free Mindset. And he's really on a mission to interrogate the myths and to flesh out the theories of pain management, and is taking a real holistic and a trauma-informed approach to pain management. So welcome, Deepak. It's really an honor to have you on the show.
Well, thank you, Zina, for having me, and it's been a pleasure to be on this channel today for the Health Coaches Academy, and I look forward to this conversation this morning.
Absolutely, me too. I think it's such an important conversation to have. And I want to start with, obviously, you're all about pain management, right? So that's your thing, and that's your area of specialty. So let's start with the standard approaches to pain management. What's out there currently? What are they? And what are your thoughts on them?
Well, I think for a long time, the standard approach to pain management has been to say that if somebody experiences pain, so for example, if someone has an episode of low back pain, then the usual approach, and this must be common across most continents, most countries of the world, is that you try to initially manage it by doing some gentle stretches. Maybe you go to your physiotherapist or an osteopath or a chiropractor. And then if things don't feel right, or you've got symptoms that are feeling more severe, you take some pain medications, some off over the counter or some from your GP or specialist. And the next step usually is going for some kind of a scan or imaging, and you then go and see a surgeon to see if this is something structurally wrong with either the disc or the bone, etc. That is usually the standard thought process about pain. And implicit in all of this is the assumption that when pain occurs, it must be coming from a part of the body. And that part of the body can either be moved or pulled or pushed or modified. And everything, the cause of the problem must be that part of the body. And that's been the prevailing view of pain, and the way of managing it, therefore, has been about something physical, something to be done to an area of the body, and that usually should relieve the pain, is been the premise. The reality, though, is that pain is right now the most prevalent long-term condition on the planet. It is a condition that affects 20% of the global population. So therefore, if you're thinking of the population of the world is about coming close to 8 billion, we are saying that roughly 1.6 billion of the world population. And certainly, for example, in the UK, there's data to say that up to 28 million, which is almost 40% of the UK population, has got chronic pain, which means pain that is lasting for 3 months or more. And that has really called into question this whole premise that is all pain just coming from a structure in the body always. And that's what the research now over the last 20 years is starting to show some really exciting new findings, but also findings that say that our prevailing understanding of what gets taught in medical schools, in healthcare schools, I'm not saying just medical doctors, but what gets taught to physios, to osteopaths, to chiropractors, any healthcare professional, that understanding of pain is actually outdated, flawed, and is one of the reasons why, for example, low back pain or musculoskeletal pain usually is the biggest reason for any economy's reason for sickness, productivity loss, and return back to work. That is the challenge right now. Certainly in the UK and in the US, musculoskeletal conditions, low back pain, neck pain, headache, These are some of the top 10 most common reasons for people who are in the employment age to not be in employment, to be off sick, to be on government benefits, to have carers looking after them. So it has widespread society ramifications if you don't look at pain with the right scientific lens.
Oh, wow. I didn't realize that that's, one of the top reasons why people don't show up for work. And obviously that has a huge economical, financial cost as well. But you mentioned something. So you were saying that the common belief or perception is that pain comes from, there must be something wrong with a certain part of the body. If that's not the case, where does pain come from?
Really great question. And I think that's important to address it right from the outset is that if I say that actually pain does not necessarily come from the structure, what do I mean? What exactly we have all been taught is a not a myth, but it was the prevailing scientific understanding in the 1600s and 1700s was that, and this was coming from a French philosopher called Descartes, and he had this approach wherein, at the time that he lived in France and in Europe, the church prohibited anybody from touching the human body because the human was considered to be superior to all other animals and was one with God. So the human body could not be dissected or operated upon or done anything. And his philosophy at that time really became very popular. And what he suggested was that the mind is one with God, but the body is something that is not really one with God. So it could potentially be taken apart and put together again. And in his view, because in France at that time, hydraulics and the way pipes and water pressure and all that was the prevailing way of understanding things, his view of the human body and specifically pain also was that you had some feeling of pain in your foot, let's say, and then there would be a wire that would be pulled, and this wire traveled all the way from the leg to a small part in the back of the head called the pineal gland. And the pineal gland would then open up the humors, the dark humors or the humors, and those humors would request the muscles to pull the wire so that the leg would be pulled away from the fire.
Mm.
So if you had a painful stimulus at your feet or something, there would be a series of wires and fluids, so you can see somewhat like hydraulics, to pull the body away from the source of pain. And his thesis was that therefore, if this is a wire that is carrying the information about pain, you could go in, you could look for this wire, you could cut this wire or repair this wire or numb the wire or block the wire, and that should relieve the pain.
Mm.
And that was the way we understood it. And in some ways, medical science has progressed and advanced so wonderfully because of this philosophy that the body and mind are separate. The body can be dissected and we can be very reductionistic and find which cell is responsible and change. So genetics and everything, all of the modern advances in science could be attributed to some of this thinking. But it also comes with some challenges because we realize that pain is not necessarily like a wire. There is not just one pineal gland and the signal doesn't stop in the back of the brain. What actually the science has now shown, and very fancy MRI and research scanners have shown, that when you have an injury, let's take, for example, a knee pain. If you have an injury to your knee, then you have chemicals released at the site where there's been a cut or an injury or a surgery.
Mhm.
These chemicals get transferred or converted into electrical signals.
Mhm.
That particular process is called nociception.
Mhm.
Now, nociception is not the same as pain. Those electrical signals have then got to travel in the nerves and they go to the brain, and they don't just stop in the back of the brain or they don't go to one center for pain. They go throughout the brain. They go through multiple centers, and imagine a pinball machine where the signal then just goes ping, 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 ping throughout different parts of the brain. And what the brain then is doing is actually saying, where is the signal coming from? What am I doing when this signal arrived? Have I faced this signal before in the past from the same area of the body? What did I do at that time to protect the body or protect the knee? Did I ask the muscles to clamp down? Did I keep running? Has this injury or cut happened when I am about to score a goal on a football field? Or is this happening on the middle of a busy road when a bus is about to hit me? All of these are context based decisions and thoughts and plans and predictions that the brain has got to make. And it makes this in a fraction of a second. And if it decides that it needs to bring about protection, that is when it will bring about the experience of pain. So we're realizing that it's a lot more complex. So when you experience pain in the back or in the knee, it's not just always the structure. You have to keep in mind that it may be a structure, but then this whole process of this information processing, information prediction in the brain, information decision making, and then the output. All of these also need to be kept in mind when you are deciding what to do for the pain. So when you expand the definition and understanding of pain to include all these things, that it can be the part of the body, it can be the signal that is getting transferred to the brain, it can be the brain's decision and context and prediction and protection. Then you have, in some ways it might feel complex, but for a clinician it means that now you have two, three avenues of supporting the patient. And for the patient, you have two, three ways and places to look for and try to manage, overcome, heal the pain. Because if you get stuck only in the structure and saying it must be the structure, then often you're left chasing your tail because you need to do more scans, you need to do one more scan, you need to do another CT or an MRI, or you might go for a surgery. And if the answer doesn't come, you go for a second surgery. And at some point, patients start to feel hopeless that nobody's found a solution. Surgeons and physicians will say, I don't know what to do, go somewhere else. And that is unfortunately the prevailing model we need to change and disrupt because everybody doesn't understand that the problem is bigger but can be looked at differently.
Wow, that's really interesting. So the chemicals that are produced around the site of injury, that's known as nociception, right? So that
Yes.
is not pain. That's not pain yet. It's the brain needs to interpret it as dangerous, and that's when pain is created. Am I understanding it correctly?
Absolutely. Pain is a protector signal. It's not necessarily a sign of warning that some part of the body is affected. It is a sign to say that something is wrong with the interpretation. We need to find out, is it the structure or is it something else?
Mm. So I guess there might be some intervention that could play a role when it comes to the brain, right? So intercepting the brain's perception of whether this is really dangerous or not, depending on all the stories that the brain might create from the previous time it was injured, etc. So, is there a way to, when the brain is interpreting danger signals, to help it feel safe and reduce pain as a result?
Great question, Zina. And that is where I have this philosophy and approach of a trauma-informed way of approaching this whole problem and supporting the patients is to realize that if this brain is making an interpretation that it needs to protect and it has made the decision that I will bring about pain because I need to protect, then we need to start from a place and saying, well, what is it trying to protect against? Is it the structure? So, okay, let's do the blood test, let's do the scans, let's do the part of the body to say, is there an evidence of infection, inflammation, injury, whatever at the structure? But if that is not the case, and often that is the uh, challenge, or rather, that is what we are finding now, and it's something we can cover a little later in the talk, that there are now studies showing that when you do a scan, there are already changes seen on the scan of disc bulges, disc thinning, cartilage tear, etc., when they have no pain at all. So that means changes in the structure of the body can happen independent of the pain. And therefore, if the brain is making this decision on protection, we need to say, well, what is it trying to protect against? If it's not the structure, what else might be happening in this person's life?
Mm.
What else might be happening to the nervous and immune system of this person for these two systems to decide that there is some threat against which it has to protect? And that means having a much more open and more honest, more therapeutic conversation. Something I think that health coaches almost intuitively do very well is to have that slightly open, patient centered conversation to say, well, tell me more about yourself. What else is happening? What else has happened which might have led to you having these symptoms? What was happening around the time 2 or 3 years ago when this pain first started? Was there anything else going on? Were you recovering from some other infection? Were you recovering from some surgery? Was there any stressor happening in your professional or personal life? Because all of those events will be acting on the same nervous and immune system as the injury happens on the same nervous and immune system. So the system is one, the person is one, the brain is one. It's just where these information sources are coming from. And that is what we need to be having a better understanding of.
Yes. So it's much more complex than just giving someone pain meds, for example.
Exactly. You may choose to start with that because you feel, okay, could it be a structure? Let's see. And sometimes people come. And I think this is where it's often a difficult challenge for example, GPs who have got only 10 minutes to 15 minutes, primary care doctors. Some surgeons are also very busy, 10 or 15 minutes. But we need that time to get this history from the patient because nobody is going to come with a full insight that in 10 minutes time they're going to say, I had this injury, but I know that at the same time I had this and this going on, so I'm sure. Then why do we need a doctor or why do we need a clinician if the patient does all this work themselves? So
Yes.
I think it's giving that time, finding that space, and having those conversations. And it might start off with saying, okay, let's try a pain meds to see if it is indeed related to a muscle or a structure. However, if it doesn't work, then I think we need to open this box up a little bit more.
Mm. And what are the stats that you've seen over the years? How effective have you found pain medication to be in most cases?
This is the other side of the challenge, which goes, in fact, so, we talked about why pain is so prevalent, and because we're coming from a false understanding or rather an outdated understanding. And we are now parallelly discovering that the drugs we had for pain, whether that's the simple ones like paracetamol or the anti-inflammatories or the weak opioids like codeine or tramadol or even the strong opioids like morphine or fentanyl or oxycodone, and then you've got the other sort of nerve medications that are used, drugs that were used for epilepsy or depression were repurposed and used for nerve pain. All of these drugs, unfortunately, no drug is free of side effects. You have to tailor it for the right patient at the right time for the right duration. And we have seen the problems that have come from the US, and we are seeing it certainly in some parts of the UK, that prescription medication misuse and abuse and diversion, addiction is a big, big problem. This was not something we fully understood and recognized when these drugs came on the market. But now, in the last 10 years, we've also become aware that the drugs that we have been using for pain work. And I have this kind of catchy way of remembering it is 30, 30, 30. They work for about 30% of the people with 30% efficacy and only 30% of the time,
Wow.
which means that most drugs are not that super effective. They don't work for 70% of the population. And it means that we need to have something different and better, or at least something more than just pain medications alone. We can't depend on the drugs alone because they not only, are not that effective, but they also have then side effects which are making them less suitable for many groups of patients. Drugs, when they are researched, they are very carefully researched in very clear, select populations. You do these things called randomized controlled trials where you are making sure you have got two groups of exactly similar kind of things with no major issues, and then you find out whether the drug is superior to the placebo or the control, and that's when you say this drug is better. But then you've done it only in a tightly controlled group. These patients don't have usually difficult mental health issues. These people don't have other long-term conditions. But the reality is often very messy. 60% of people with chronic pain have got depression or anxiety that can be quite significant. Up to 20 to 30% will have features of PTSD. So there are coexisting mental health issues. Neurodivergence is a big issue there, which impacts on how people take drugs. 50 to 60% of chronic pain patients have got diabetes or some other long-term health condition as well. So we haven't tested the drugs exactly in the pragmatic real life. We've done it in carefully controlled environments. So it's no surprise that when we spread it to the rest of the population, we realize that they are not as effective as they ought to be.
Mm. But I find it really interesting that it still in many societies is the go-to. It's the go-to solution for most people in pain. And you mentioned earlier that this might be because it's convenient, it's easy, the doctors don't have a lot of time, it's a easy first step. Or what else? Do you think that's the main reason why it's still the go-to solution?
Well, we've seen it in every other industry. Convenience tops everything else. Convenience is the attention grabber, and if something is convenient, humans and human brains are energy optimizing machines. So, ultimate machines is the wrong word, but energy optimization is the ultimate outcome for every organism. And so, if things are convenient and the brain doesn't have to expend too much energy or time, then it's easy to do it. So, drugs in that sense are very passive. Somebody gives it, you take it, and job done. So, that's one reason. The
Yeah.
other reason is actually we've got 250, 300 years. Descartes lived in the 1600s. His philosophy has been around since 1650. So, for a long time, we've had this way of thinking about pain that there must be a tablet you take and you just get on with life because it's passive and convenient. And that's how society thinks about it. And the third thing is we have to do something almost at a public health level to actually change this perception and get a different conversation happening around pain, because right now social media and a lot of society still plays to this fact that if you have pain, then you just take something and move on. You've got popular series like House on Netflix or wherever it is, and they all promote this thing that if you got just pain, just take a couple of pills and carry on. So unless and until we change the societal interpretation and perception that pain doesn't mean you just stick with drugs, that we need to adopt a slightly wider approach, we will always have this difficult problem of moving people from drugs to something else.
But I agree that it needs to take place, that shift needs to take place on maybe a public health level, in order to really create change. But the next step, often, as you mentioned earlier, after taking meds and maybe it's not working as well, then MRI scans or some form of a scan is often the next step, like you said. But I find it really interesting what you've mentioned earlier. So most people, if you do a scan, will show some form of, there might be a tear, there might be some issue, and even though they might not be experiencing any pain. So that's interesting. That brings it back to the brain's perception, I guess, of pain and whether it's seen as dangerous or not. So MRI scans are not necessarily seen as, or are necessarily definitive, right? That's not the only indication of whether something's wrong or not, like you explained earlier.
Absolutely, Zina. That is something even now when I tell my healthcare colleagues themselves, not just patients, they're often surprised, and it's difficult for my clinical colleagues themselves to also wrap it around their head, and they'll say, oh, no, no, something must be not right with the study there. But the
Mhm.
studies have been done. The studies have been done in the last 10 to 12 years, and they are very clear that when you do an MRI scan on people who have no pain, you just told them that, and everybody, if they're getting a free scan, they don't have a problem, I reckon. But we have studies that have been done, for example, on the back, on the neck, on the hips, and the knees, and the shoulders. So these are, from orthopedic perspective, these are the five most common areas where people say, oh, arthritis, etc. But the example, for example, the study that was done in the hips, 69% of the people who had no pain had a tear in their labral cartilage.
69. Wow.
43 out of 44 people who had MRIs of their knee. So 43 out of 44 had meniscal thinning or tears in their knee cartilage.
That's great.
80% of 50-year-olds had a disc bulge. They had no pain. 60% of 50-year-olds had a disc degeneration, but no pain. And up to 58 to 60% of the guys who had their people who had their MRIs of the shoulder had also tears in the cartilage of the shoulder. So when you then have your first episode of pain and a surgeon or someone says, let's get a scan done, and the scan does show a tear or a thinning, then how can anybody be absolutely confident that it is that episode of pain that has happened because the tear has happened at the same time? Or was this tear already there for a few months or a few years before, and it just got discovered because somebody had an episode of pain and you got a scan done? So it's very important that we understand this and we are open to discussing this with the patient. In some ways, this is where the skill of the clinician comes along, is we are aware that the MRI can show up unusual, unnecessary, unrelated findings, and we need to tell our patients that, okay, I can do the scan for you, but it is possible that there may be already these changes. So let's do a scan and then review what the changes are and whether they really are in keeping with the symptoms that you have. Because just because you have a change on your scan doesn't mean that's the reason for your pain. People will feel that that should be the reason, but that is where the skill of the clinician and the need of the clinician to be comprehensive in their outlook is important, because that's what's happening in the UK now. We've realized that for a long time we have moved the pendulum too far. We would be entirely dependent on a scan and we make all the decision based on a scan. But nowadays we are sort of trying to push the needle back to the middle to actually say it's important to have a good conversation after the scan with the patient to actually decide this, discuss the scan results, and then see if it really matches up, and be prepared to have a conversation with the patient to say, what else can we do if the scan is not the main reason for the pain?
So it shows me that you can live a good quality life even though there is a tear wherever, like you said, most people have it. And it's so important to listen out and to have that conversation, and take the time to figure out, but what else is going on? Because the next step, when a physician picks up on a tear, is often surgery, right? Or not always, but sometimes, right?
But that becomes the default. You either you either offer an injection or an epidural or something, or you say, oh, maybe you almost get blindsided into a one-way rabbit hole which says, oh, we can do this injection or we can do another injection and then we do a surgery. And all of that seems very intuitive and obviously logical to a patient and the surgeon, because that seems to be the right thing because you've now found something on the scan. And I think it is the skill of that surgeon or the clinician at the front end to actually say, okay, that is one rabbit hole, but it doesn't have to be that way. and keeping that door open for the patient is very critical. And this is where I think every clinician needs to have a little bit of that coaching based skill to actually say, okay, what is it that you want exactly? If we did this one or two injections and it worked, what would you do different? What would you go back to doing different? What are your priorities in life? Because we don't have to go down this route and say that surgery is going to resolve the problem. There will be some conditions where that is the obvious route to go down. But for most things in pain management, we are realizing that the door has to be much wider. It cannot just become one rabbit hole wherein you just do two injections and a surgery. You have to approach it. And indeed, there are organizations called Choosing Wisely across many countries of the world where they advocate that both patients and surgeons, before they embark on any interventions, undertake this exercise where both parties are fully aware of what the benefits of the interventions are,
Mm.
what the risks of the interventions are, a discussion of what the alternatives to these interventions are, and actually a fourth point to actually say, what if you do nothing? What will then happen over the next 12 to 24 months? So this is called the BRAN principle. And it's important that both patients and clinicians engage in this exercise, document it so that both patient and clinician are clear that what they want from this set of procedures are aligned and similar. Because often the surgeon will think, oh, yes, I can take out the disc and that'll be done. I would have sorted the problem. But the patient will have a different set of thoughts in their mind. For them, it might be about going to play with their son or their grandson or child, or it might be to be traveling to work or being able to sit for an hour longer. And that may not be the thing that the surgeon can actually promise, but that's what the patient thinks they want. So I think we need to get that alignment right so
Mm.
that the outcomes are exactly what everybody hoped. Because if that doesn't happen, that's where patients are going to feel like they've been misinformed or unhappy. And that's where complaints and litigation and everything comes because you've not managed expectations right from the outset.
Exactly. That's absolutely crucial. But if I think about the mind, so you talked about the brain and how it might perceive something as dangerous or not, but obviously the title of your book is The Pain-Free Mindset. So the role the mind plays in all of this, I find really interesting. So you mentioned a placebo earlier with drugs. It's part of any good study needs to include a placebo, right? So if someone think they are getting a certain type of medication, sometimes they heal or they feel better. They feel much better just because they're thinking they're getting some support. So do you think the same could apply with something like surgery, where the mind might play a role like, oh, wow, I got surgery, so I should start feeling better? What's the role of the mind when it comes to surgery, do you think?
Well, great question, Zina. And I think there are a couple of strands here that I want to unpick out here. The first thing is actually the title of the book is sort of the pain-free mindset. But for me, there were two reasons. There were two reasons I used the word there. One, of course, as you rightly said, there is now an increasing appreciation of the mind and how it is set in terms of how it deals with protection signals. The second was the mindset at a more banal level is actually that is an acronym in itself. So for me, mindset, it was a easy to remember acronym for M meaning medications, I being interventions, N being the neuroscience, D being the diet and nutrition, S being the sleep, E being exercise or movement, and T being therapies of mind and body. So to me, you
Mm,
see how easily that rolled out to me.
I like.
It helped me capture everything that I need to be thinking about for a patient in front of me. What are the seven pillars by which I give a personalized plan to my patient? Would be based on these seven pillars.
Mm,
So I'm not throwing the baby out of the bathwater. I'm not saying there's no need for medications or interventions. The question is, how do we integrate these seven pillars to
yeah.
create the right kind of toolkit for the patient in front of me? So that's the reason the title is put that way there. In all of this, the mind part of it is very crucial. In some ways, that's why the N, the neuroscience, sort of sits somewhere close to the middle. I wanted to think of a word that would feel like it sits at the top there of the pyramid, the neuroscience part, because that is the crucial part. And You alluded to two things. One is the placebo effect, and it is so important right now because we've often thought about placebo, and during medical school, the thought you are is like, oh, placebo is a sugar pill. That means it's useless. And if something is called a placebo, you almost are made to poo-poo it and say that's bad. But we are actually, exactly as you said, the placebo response is 30%, which means in any study, up to one third of the people are getting benefit just because they are taking something. It doesn't have to be the actual drug, which means now the neuroscience is actually saying what happens when you take a placebo. If those one third of people are responding, what is actually changing? And we're realizing that placebo is not inert, it's not a sugar pill, it has got its own actual biological and sometimes therapeutic outcome. It activates the brain circuits in the same way as a drug does, sometimes as effectively as the drug does, and sometimes even better than an actual drug would do. So we are now saying that a placebo response should not be looked and called upon just as a placebo response. We should think about it like an expectation response. It's a meaning response. What is the brain making a meaning of when it is presented something that's big and red or blue, or what is the context in which it comes? And for that matter, one of the Australian surgeons called Ian Harris wrote a book called Surgery, the Ultimate Placebo, where he actually has looked at all the surgeries, and he is now spearheading a movement where they are saying if you are introducing a drug into the market only after doing studies comparing it to a placebo and saying it's superior to a placebo, then we should be also doing surgeries, and we should be doing surgeries against sham surgeries or placebo surgeries. And if that surgery is superior to the placebo surgery, only then it must be allowed to be reimbursed and paid for by insurance and allowed onto the market. And he has done a couple himself, but in the UK, I'm aware that they have done these kind of double blind, sham controlled arthroscopies of the knee and the shoulder. So they have actually had two groups of people who have come in for a knee washout surgery under general anesthesia. And these groups are exactly treated the same until the time they come into the operating theater and they are put off to sleep.
Mm.
At that time, the envelope is opened and you see which group this person belongs to. Do they belong to the sham group or do they belong to the surgery group? So if they belong to the surgery group, the surgeon would carry on the washout, trim the cartilage, etc., in the knee, whatever, wash it up and clean it up, and then wake the patient up, and the patient would go on to get a 6 to 9 months or whatever in the study of physio and rehabilitation. If the envelope opened and it revealed that it was the sham group, the patient would just have two bandages put on the outside of their knee. They have already been anesthetized. They're under general anesthesia, but they just have two bandages in the knee. And then they'd be woken up and they'd be given the same 6 to 9 months of physio and rehab. Obviously, the patient is not told which group they are in. The nurses and the theater team are aware, but the researchers are not aware. So the researchers also don't know what the patients have had. So that is the double blind element. The patient and the researchers do not know. And when they looked at the study 12 months later, there was no difference between the two groups in terms of return to work, use of pain medications, response to physiotherapy and rehab. So that is the reason why in the UK, knee arthroscopies are now not being often funded by the NHS, by the National Health Service.
Wow.
The same outcome happened when they looked at shoulder washouts as well. And the same happened when they looked at tennis elbow surgery and when they looked at cement injections for disc or fractured bones in elderly people, vertebroplasty. So at this time, we do not have a good enough trial to say that any one particular surgery is superior to actually sham controlled surgery. Every surgery that's been introduced and done anywhere in the world, apart from maybe hip replacement or knee replacements, has been introduced only because there's been a charismatic surgeon, there's been some plausible biological mechanism, and there have been a few case studies of success. There's been no proper evaluation of it. That is the challenge which surgeons and surgery and systems face. So, unless and until we can be open about saying that placebo is a lot of things. The whole thing might be that the fact that you tell a person to, you're coming in for surgery, you're going to have this thing done, you're going to come into a hospital setting, you get changed, there's a ritual, you've worn a dress, you've gone under anesthesia. So this whole ritual effect, the meaning of what you've gone through, that is a big thing. And in back pain, this is just so there was a gentleman by the name of Michael Mosley, who was a very well respected TV presenter in the UK. He did a very interesting study along with a couple of Oxford researchers a few years ago in a city in the UK called Blackpool, where he said, well, we've got this new drug for back pain. And this drug is nice and big and blue. And then we've got the usual placebo drug. And we want to see this drug and see whether it will be helpful. So we're going to randomize two groups of people with back pain in Blackpool. And this was all televised. So this was completely televised. This whole experiment was under the scrutiny of television, and the patients were interviewed in the run up to surgery. The people who were going to be given the new blue colored big drug were given 30-minute GP appointments. They were dealt with sympathetically. They were told about the new drug, how to take it, what to do, etc. And then there was this other group of people who were just given the standard 10-minute GP appointment, given the drug, and they carried on with it. And they were followed up at the 2 month or 3 month and 6 month mark. And they had these wonderful stories of people like somebody who was on ketamine, who was on morphine, who was on all kinds of drugs, who was wheelchair restricted and desperately wanted to just be able to go to his houseboat, which he hadn't been able to go for 2 years. By taking this new drug that was done, within 2 or 3 months, he was able to come off the ketamine and he was able to get off the wheelchair, use some crutches, and they showed him getting into his houseboat. And it was so awesome and wonderful that this drug made such a big difference. And then at the 3 month or 6 month mark, I forget which, the television crews all crammed together for this big arrangement and meeting in the town hall where Michael Mosley and the researchers all came together. All the people were assembled, both the groups were assembled, and Michael Mosley then gave this outcome that actually both groups got just a placebo drug. The blue pill was also a placebo, the placebo was also a placebo, and that's it. And,
Wow.
and how do you then make sense of it? How do you explain it? Because none of the drugs had any active ingredient,
Oh,
yet there
wow.
were people who were able to stop their morphine, their ketamine, they were able to achieve things they had not done for 3 years. And that is the power of the placebo or the meaning response. That is the power of the brain in some people. We need to be doing more research
Yeah.
on placebo to say how this actually made a difference rather than ignoring the placebo.
I think these stories are brilliant. I'm so glad you shared them with us. And you're so right. We need to do more research on this phenomenon. It has the capacity to obviously heal people and to make a big shift for people. So this is obviously one of the things that you listen out for. So you mentioned earlier that that's the role of the health coach. That's the role that the physician could possibly take in is to listen out for, what's going on for this person. What else should we be looking at? So what are some of the things that you pick up on when you have a conversation with a patient? If it's, if it can't really, we can't do much in terms of medication or surgery or MRI scans, then what else do you typically pick up on?
So, my conversations with a lot of patients, luckily, with my role as a consultant, I do have the advantage of 30 to 45-minute consults. And these days, I actually have some appointments that go for an hour. And a lot of time, my first consultation is all about rapport building,
Mm.
is all about understanding the story of the patient, where they have come from. I work also, and I'm trained also as a pain coach. I train other people in this role of health coaching for pain management. So, a role that I sort of then act out in my own clinical sphere is to first spend the first 15, 20 minutes listening to the story, validating what they have told me, trying to make and help them make sense of how their symptoms have changed over time. I think that's very critical and very crucial.
Mm.
What I've also realized is sometimes I can get some of the other information in advance. So both in my NHS and my private practice, I do have a questionnaire that goes out to the patient in advance, and I encourage them to fill that information out, because then that gives me a list of whatever drugs they're on, what their other conditions are, what their scores for anxiety, depression, worry, and I also do one scale for adverse childhood experiences, sort of just the ACEs score. So I have this information hopefully to hand before they come into the clinic. I have an idea of what drugs they are on when they come into the clinic. And I also ask them, like, what do you think the pain clinic can do for you? Sometimes it's just an open question, because it gives me an idea of how they are going to be expecting, what their expectations are. And as I told you, it's part of the brand principle is I need to know where their expectations are, so that I can make the clinical consultation, the time I'm spending with them and they're spending with me, of value. Because if I just go off on my high horse and I don't address their expectations, then that's going to be a challenge which I will never be able to bridge. Because once a human is in a consultation, or rather any of us are in slightly different surroundings, and that's the trauma informed picture. They are coming into a setting that's not their usual setting. They are sitting in a room which is not their usual setting. They are sitting in front of me, who they don't know other than what they've heard of. All of these, for a sensitive and overprotective nervous and immune system, are all conscious and unconscious holders of threat. They are all surveillance cameras that are going on in any person's head when things don't feel exactly familiar to them. This is the natural organism's response. And so it's about trying to bring that familiarity into the whole situation, so that they can start to feel safe. If they can let their guard down and they can volunteer more information than what the questionnaire says, that is what the first consultation is about. And sometimes their expectations are very clear, that I think there's something wrong, or I've been told there's something wrong, or I've had this thing before and I think this was solved with an injection or a scan or something before.
Mm.
Then that's something very important for me to know, so that
Mm.
the first step of rapport building might be to say, okay, let's do another scan again, or let's try the same medication again. But the question I do ask is, well, what if it doesn't work? Or given the scores you have told me, it is possible that your nervous and immune system is more sensitive. So if this drug or this injection or the scan doesn't really give us the answer, what next? And that's just an open question. And you can see here that a lot of what I'm suggesting or doing is kind of coming into that space of motivational interviewing. A little bit of open questions, a little bit of assumptions, getting them to reflect on some of the assumptions they have made or the beliefs they have. I think all of these are opportunities to explore that if the patient is in a safe space.
Yes. Oh, that's crucial to create a safe space for a client to open up and to really share with you what's going on.
Yeah.
You mentioned an overprotective nervous and immune system. What might cause that?
So this is where the brain's next capacity comes along, is that we talked earlier about the brain predicting or trying to decide whether it has faced a certain signal in the past before and what has it done in the past to protect you. In some ways, I think of it like the way we talk about all these new large language models like ChatGPT or Gemini or Claude. all these large language models are essentially prediction machines. They're machines, but they are being designed based on the brain's neural networks and how researchers and artificial intelligence researchers have understood the brain is what they are trying to bring into these large language models. You train these large language models with a data set, you train them again and again, you fine tune them so that when you next ask them a question, they can give you a cohesive, coherent response that feels like it's saying the truth. So it's important that the data set that it is being trained on is also good quality and good information. And in some ways, the prediction model that the brain builds in itself of how to protect itself is based on all its past experiences and what models and what data sets it has had right from the time it's growing up, right from the time it has interacted with society, with family, with friends, with school, with digital media, television. All of those are forming data sets for the brain to create a model on how to exist and survive in this world safely. Because ultimately, the job that the nervous and immune system does in any one of us is to enable us to survive, maybe thrive, and effectively procreate so that as a species we carry on. At an evolutionary biology level, that's what the human organism and the nervous and immune system does is to look out for threats, protect us, keep us alive, ensure we procreate, and that the species can carry on. That is at the simplest level,
Yeah.
which means the nervous and immune system's role is to look out for these kind of threats, build up these prediction models within the nervous system so that it can conserve energy, not use up unnecessary energy every time to keep making 100 decisions, but to have a clear set of decisions and it will act it out. And this means that in some people, that protection system can become oversensitive. The nervous and immune systems models can be so fine-tuned and so heavily calibrated that even what we might consider relatively harmless stimuli or sensations can become extremely sensitive for the nervous and immune system. This is what I think is happening sometimes in some cases of neurodiversity and anxiety is a nervous and immune system that's highly hypervigilant and looking out for threat
Yes.
because it has to act out very quickly to protect itself. So that can manifest as high anxiety. On the other hand, it might manifest as extreme high, so I might as well just withdraw completely from society because that at least will keep me safe. And that might be viewed as depression. It might be extremely protective where everything goes into a spasm, and that could be a form of chronic pain. So we are aware that these days the nervous and immune system can respond to a variety of threats from both the outside, which will come through the eyes, the skin, the nose, and the ear, and from the inside, which is where I think the gut, the immune system in the gut, the microbiome, all of that, because the biggest response or presence of the immune system is around the gut. So the internal part there acts up. All of these are the sensory surfaces through which our nervous and immune system can keep getting signals, take actions, correspond to the data set. And in some people, it can just be so fine-tuned that it becomes really oversensitive.
Hmm. So it is, the nervous system tends to go into overdrive when there's some form of a threat, even though it was many years ago. And you alluded to the adverse childhood experiences, the ACE scores,
Yes.
and traumatic events that perhaps also took place when you were younger or, even recently. So I know there's an interesting stat. I don't have it with me right now, but I'm sure you'll be able to share. But the ACE score, how that links to chronic pain or certain conditions later in life. I know that if someone had more than 2 or 3 adverse childhood experiences, they tend to have more pain or suffer from conditions like fibromyalgia later in life. I don't know if you have the stats or more or less an idea of how that works.
So You're right, Zina, in that part there, that there is a very clear association between having more ACEs
Mm,
and having more chronic pain in adulthood. There's now very good UK Biobank and meta-analysis and systematic reviews that have come out in the last 3, 4 months itself that have shown that there is a huge increase in other comorbidities as well as chronic pain and other kinds of chronic pain conditions, almost 3 times more
mm,
chronic pain conditions has the ACEs increase. And they say that for every one ACE increase, there is a 13% increase in comorbidities in other conditions, health conditions. That is the broad picture.
mm.
There are some caveats here, and we must be aware that it's not causation. So
Yeah.
this is an association. It doesn't mean if
Mm,
you have ACEs, it will be causing. So that we don't know that for as yet because no studies have been done to establish causation. So that's something for your listeners. I want to be very clear. The second is ACEs, as talked about in the original study, only refers to 10 events that the original authors in the study from the 1990s talked about.
mm.
It talked about only in the context of childhood, so less than the age of 18.
Okay.
There are many more adversities and traumas that can happen to an adult or a child human at any time. And that can be bullying, that can be separation, that can be divorce, that can be bereavement, that can be abuse, domestic abuse, violence, whatever that is happening in many countries these days, conflict related traumas.
Mm,
All of these are not really covered and picked up and studied properly. And we must be careful that there are possibilities of overestimation and underestimation depending on how we study this. So that is sort of the second caveat to be aware that the ACEs don't tell the full story themselves.
yeah.
However, the principle holds in that if humans are exposed to traumatic events of any kind or stressors. Ultimately, trauma is a form of stressor. And as Gabor Mate said, when trauma happens or stress happens, it's not that trauma happens to the body, it's actually what happens inside of the body when trauma or stress happens to the body. And
Mm,
that means it might be the same event, but what happens inside of the body can be different in two people. So, two
yeah.
people can experience the same car accident, but how they both respond, how their immune and nervous systems respond to the trauma will vary from person to person. We can't extrapolate and say, oh, I was in the same car accident and I didn't have any such issues. So the other person is just making it up or simply being just putting it on is not the right thing. So that's the important part to remember. With that set of caveats and assumptions in mind, the principles that hold there is that small periods of acute stress, the nervous and immune system is ready to cope with it and can learn from it and can grow from it. So that post-traumatic growth,
Mm,
all of that can happen. But when trauma is persistent or intense or continuous,
mm,
the brain, the nervous system, the immune system, and the hormone system, the endocrine system's ability to continuously respond in a normal fashion is overwhelmed.
mm,
And that is where the system starts to function abnormally. And that can happen at any age, but the theory seems to suggest that the younger it happens, whether it happens in the first 1,000 days or it happens around puberty or in 15, 16 years, the changes to the neural circuits and how it wires up differently
mm,
can sometimes be more enduring. So people who have had ACEs when their trauma is intense and has happened at younger time when the nervous system is still highly actively developing and circuits are forming and wiring and rewiring, the changes that happen to the circuits at that time could be more enduring. And that is what the data seems to indicate, that if you've had significant ACEs, then by the time you reach your 20s and 30s, it's not just chronic pain or mental health issues. You could have autoimmune conditions, you could have liver problems, you could have heart disease, you could have cancer related problems. So it is all physical health conditions as well that start to pile on to your nervous and immune system's inability to function optimally. In the end, it seems to indicate that people with lots more ACEs may end up dying 20 years on average earlier than
Wow.
someone who has had a relatively free of ACEs childhood. That is really unusual because 50% of the population have at least one ACE,
Mm,
and four adverse childhood experiences seems to be a clinically significant cutoff.
mm,
But I've had patients who have had nine ACEs come to me and they have got good family support, good resilience, and are holding a job. And yes, they've had their episode of back pain and they've come to see me. And I've had people with just one ACE who are absolutely struggling and are in a very difficult place. So I don't hold
yeah.
the ACEs to any kind of measure. It's not something that I'm going to decide like a blood test to say that yes, it's high or low.
Mm,
All I'm aware is if somebody has got high ACEs, it means their nervous and immune system is likely to be more vulnerable.
yeah.
And if I now find out in the clinical consultation that they are in a difficult social environment, meaning that they don't have support, their resilience factors are lower, their job is under risk, their family situation is a little bit of a difficulty, then that means that my conversation with them will be like, look, your nervous and immune system is vulnerable. Your social protection and support system right now is a little bit less. So
Mm,
if I were to give you a strong drug like an opioid at this time, the chances are that the risk of addiction is a lot higher.
mm,
So I need to be cautious and you need to be cautious that we don't risk your nervous and immune system when it is vulnerable to get that relief that a drug might give, because that will be what makes the drug then addictive.
mm,
Because my view is that morphine and oxycodone and any other potentially addictive drug, it's not the drug that is addictive in itself because it acts on the reward pathway.
mm,
It's actually the timing of when you give the drug to the person, the social system that the person is part of, that raises the risk of this drug triggering the reward circuits in such a way that the reward circuits say, I want more of that all the time. And that can happen with chocolate, that can happen with internet, that can happen with porn, that can happen with shopping. The system is the same. It's just that at this time it's a morphine, other times it might be a donut.
yeah, exactly. So if the nervous system and immune system is vulnerable or oversensitive, is there a way out, or is this kind of something that someone would need to live with for the rest of their life? Is there a practical way to calm the nervous system?
Absolutely. That is what now the research is showing, and that is what has allowed my practice to evolve and change to where it is now, because my whole focus of the consultation is to actually say, what can I do to help you calm your nervous and immune system down? How can I be part of the journey to help you calm it down? Because to a certain extent, there are certain responsibilities involved. It's not something that's passive. I can't calm it down using a machine or using something external. This is something that almost in most patients will require them also to come to the party and actually be part of the solution in
Yeah.
calming the nervous and immune systems down. So sometimes the conversation is about saying, so in my coaching head, I've got these sort of levels of activation. It comes from the patient activation measure, which is a tool in the US that they use, wherein some patients will feel extremely overwhelmed and disengaged, and they will be in a phase where they are not ready to really know what it is. And
Mm,
at that time, we may have to adopt a slightly passive thing to say, okay, can you do something? Give them the advice. And it might be that we give a drug or something just to start the process.
yeah.
But the aim then is to say, how can I empower you or make you feel like you're ready to take the first step towards there? Because then we can do so many things to calm your nervous and immune system. So the things that I talk about in calming the immune system down usually revolve around microbiome and gut and dietary modification. So that is one way to calm the immune system. Calming the nervous system down at its fundamental level starts by regulating the autonomic nervous system, which is the unconscious part of the nervous system. So that would be breathing techniques, vagal techniques, of any other resources to amplify the work of the vagal nerve. So that is cold water, or some of those gentle techniques that can just grounding approaches. All of those would be the initial set of techniques to calm the nervous system. Yes, if drugs are an option or an injection is an option to just kickstart it, fine. But it needs to be a wraparound approach of both these techniques. And that is where the conversation will come to say which are the ones patients would like. Some patients are happy with massage as a gentle technique to try. Other people might be wanting to do a bit of yoga or Pilates. Others might say, I don't want to do any of those things. I want something more passive like acupuncture. But the choices vary, and some might have chiropractors or osteopaths. Ultimately, that is a discussion that emerges, and the choice of what set of techniques they will have will emerge after discussion with the patient. But the hope is that there are these techniques, there are things that can be done, and neuroplasticity, the ability of the brain to unlearn and relearn something, is always present in every one of us. So I believe in that optimism, and in that ability of the brain to still unlearn and relearn. And that is where I think there still can be changes. So it's not a done deal that you're stuck with it, but you can make improvements. What we don't know is how long it will take. And sometimes that path can be very difficult. And so sometimes just taking small steps in the right direction is important, and adjusting as we make those changes is important, and staying the long course is important. And that is where I think coaching can be really helpful. The challenge, which you might have picked up on, is if it is going to be long or unpredictable, then does it need human coaches at all time, or is there a role for technology to play a part in making some of these things asynchronous or automated in some ways? That is an interesting area of research. Could virtual reality be a role to play? I was just talking at the South African Congress last week. I was talking about the role of virtual technologies in pain management, and I was doing some research on that part. I just updating my knowledge, and I realized that one of the big places that VR is playing now is, can you have that kind of psychological and coaching based support that is delivered through a VR approach, so that when you do have a flare up or when you do need to see something in some groups of people, could a VR headset be that way to get over a setback or a flare up using some coaching strategies at the time when they want it? Because if you're having a flare up and you don't have your personal coach next to you, and you don't have the money or the resources or the time to just call and immediately be connected to a coach,
Yeah,
then what do you do?
yeah, exactly. No, that's great. So I think there's a huge role to play for, in being part of the solution yourself, but having that support to know what exactly the step is that you can take right now.
Yeah,
Because it is going to be individual, it's going to depend on every person's situation. So
absolutely.
have you worked with patients where you helped them to calm, or they themselves calm their nervous systems, and then there was a significant reduction in their pain? Have you seen?
Absolutely.
Okay.
Yes, I do have at least 2 to 3 patients a month who have had that experience, who are grateful that at least they have a plan on how they can overcome this. Sometimes I have to link them up with a coach. Sometimes they may need a psychologist or a physiotherapist to start the process. I work with a team like that who are able to bring that kind of psychologically informed approaches to their physio practice, to their psychology based approaches. So I think that kind of model and support is possible. There are now organizations and apps, for example, like Curable, and there are a few other websites in the UK that I signpost patients to where they can get that bit of external support to say that they are not feeling alone, that they can start this process of calming the system down, and that those techniques are making a difference. That kind of approach does make a big difference. It allows them from not having to take more medications. And yes, so do I do have patients that under. Is it frequent? I think not yet, because that is something that's still evolving. A lot of patients are still in the place where they come to first hear and they hear me say this, they still have to process it and be ready. As I said, they're often in that level 1 or 2 where they are still sort of overwhelmed with their pain, their
Mm.
suffering, their distress. They can't see themselves as ready to, oh, yes, I'm ready to work on it. I know how to do it. I can do it myself. They're not at that stage. They still are at that stage where they want a little bit of hand holding and support to be shown it's possible and to actually do it continuously. Because at a biological or at a neuroscience level, what we are trying to do is you've got these neural circuits that are right now fired up in one way, where they've either taken drugs or they've waited for a scan or an injection and done that. And when I'm suggesting a slightly different way of doing it, calming the nervous system down using something else is effectively learning a new circuit, creating a new nerve circuit that becomes the preferred way for the brain to act, for the new prediction model to take. That, according to studies, can take anywhere on an average between 3 weeks to 8 months.
Yeah.
And that's something we don't have an idea when the patient isn't sitting in front of me, is whether they belong to the 3 week camp or the 8 month camp.
Mm.
And that is when you do that particular technique 2 to 3 times a day for 3 weeks. In some people, the new circuits can fall in place in 3 weeks. In some people, it can take many months. So that is where it's difficult for any of us to know how we would allow for unlearning and relearning to happen.
Mm. So it might be a longer term solution, which also needs a bit more patience, and not everyone has that type of patience, I guess.
Yeah.
So if someone's listening today and they want more, what can you offer them? So of course, there's the pain-free mindset book that they could read. What else do you do? Do you run any programs or training programs that they might could join, perhaps?
Yeah, so I do, obviously the book and the audio book are there. I do a lot of talks around the UK, absolutely, and internationally there. I am clinically, I am sort of consulting and I have a link to a team. So, in terms of clinical practice, I do have a variety of approaches to see patients internationally and nationally. I think nationally is easiest because internationally has all these insurance issues, but I do advise and provide support across the world. And at a training level here, I am in the process. Right now, I do not have sort of training programs, but in the past, I have supported, I think, occupational therapists in South Africa to create a training program for them. In the UK, I've created a lifestyle medicine based approach for pain management, and that is something that I'm working with the Learning Academy of the British Society of Lifestyle Medicine. I've got a training program that's CPD accredited, that's through them that I offer there. So there are these places. And of course, I put out a lot of content through my YouTube channel. So please subscribe to my YouTube channel. And later on this year, I'm planning to have a few courses and programs on my site for healthcare professionals as well. So yes, if you subscribe to the channel and to the social media platforms, that'll all be on there.
Okay. And the website's name, is it just Dr. Deepak?
deepakravindran.co.uk, and the clinical site is Berkshire Pain Clinic.
All right, thank you. Okay, so I know we touched on a lot of things today, but you'll surprised at how much we didn't touch on. I'm sure it's such a broad topic. So I just want to ask you if there's anything else, any last thoughts maybe, or something that we didn't touch on that you still want to leave our listeners with today.
No, I think there's a lot of things, as you said, Zena, we could have gone on there. I think there's a big role for nutrition and those kind of tangible treatment options. So please do check out my book and my audiobook to get an idea of all of that. I've had patients, healthcare professionals tell me how useful it has been for them to just get an overview of what the options are. So that I think would be definitely a good starting point. And then, of course, for a lot of the patients and the coaches who are listening here, thank you for the work that you do because I think there's going to be an increasingly huge role for coaches in the space of pain management. I do a lot of coaching and training in the UK there with an organization called Peak Health Coaching. And I think that concept of having peer support, lived experience, many of you may have had that lived experience or looking after people with chronic pain. I think the opportunities that coaching brings is huge. So thank you for the work that you do. And if there's any help I can offer, please do reach me through my social media channels. And the most important thing, maintain the hope both for yourself and for your clients and patients, because that is the biggest thing. There is hope in this new neuroscience and in this new understanding of pain science, and that healing and recovery is absolutely possible.
Absolutely. And I'm so glad that you're at the forefront of this very important change in pain management. I think it's so needed in today's world. Really listening to the client or the patient in front of you and what it is that they need, because it's complex and we need to take the bigger picture into consideration. So thank you. Thank you for sharing your very valuable time with us today and sharing your knowledge with us.
Thank you, Zina, for having me, and wonderful to meet you.
If you have a passion for health and wellness and you would like to make a difference in the lives of others and discover a new rewarding career in health and well-being coaching, visit www.healthcoachesacademy.com to find out more.